So it sounds like it's two vastly different subjects, but I assure you I'm just going to dive a little bit more into the lab values before, based on the kidney and the liver, because the ADA scientific sessions decided to experiment a lot more or do some research with type 1s and medications. So before I start a medication, I want to know the ins and outs, the pros and the cons, all the issues that go into it. And so those lab values are going to help explain a little bit more about why some people use those medications. So it's kind of a precursor into some of that data that they got on Metformin or GLP-1s, SGLT2s. We're just going to talk about them. Like I said, they're not for everyone, but we're going to talk about natural ways too to improve those lab values that everybody can do. So I'm just going to skip to the next page here. It just kind of talks about the content today, what we're talking about, so lab values, and then how to improve that. And then wrapping up the ADA 2020, and then also briefly touching on the ultra rapid insulins. Now it became a class as of FDA approval. I can't even pronounce it. It's like Lumjev or something like that. But that'll be out in market probably in 2 to 3 months. And then the Libre Freestyle 2, kind of what's different with that CGM. So we'll be talking about a few of those things. So I believe this is recording. So I'm going to do my best to kind of edit this, make sure it's succinct for you guys so that other people can see it, or that you guys can go back in time if I went a little bit fast. But just chirp in if something doesn't make sense. I've got a couple more California gals coming. So first page, I'm sure you guys are all pretty used to going to the doctor's office, and they're going to have you do a couple things, you know, the blood draw, and they're going to have you probably pee in a cup. So we're not going to dissect the whole entire lab values when it comes to it. In this page here, you'll see electrolytes and the acid base, and you'll see the proteins. Those are usually for ICU patients. They're really for intensive care or some issues going on with the patient. So we're not going to be going into that. We're really just going to be looking at BUN and creatinine. Those are going to be our markers that assess damage that's currently happening to the kidneys. So any like really short-term acute damage. And then we're going to talk about GFR, which just really stands for glomerular filtration rate. So I'm going to break that down, what that means, why that's important. We'll eventually get down into the liver labs, but this is just a sample here, just showing someone's BUN, normal levels on the right side, their results on the left side of this picture. And so why is glomerular filtration rate important? This just assesses how much fluid or how much toxins your body is filtering out per minute. So they measure it lots of times. You'll see this little picture here. I'm going to just expand it a little bit more so you can see it. That number is going to be, the labs usually only measure under 60. Some of them do a higher number too. But you can see this is the stage of chronic kidney disease, and that can be something that happens with people with diabetes, of course. Sometimes it's not even related to diabetes, but this measures the amount of fluid in milliliters per minute that your kidney can filter, basically. So when it's at full strength and it's doing really well, it's doing over 90 milliliters per minute. And once it gets down a little bit further, stage 2, stage 3, starts filtering less and less, so it's not able to get the toxins out, okay? Now this is a long, gradual road for some people, and usually it's not until way later in life that we have to kind of start thinking about this. But as that number gets down towards 15, that's when people start to need to go on dialysis, okay? So dialysis is just something where your kidneys cannot filter out enough of the toxins at one time. So it's almost like there's urine circulating in your body. You can't get the toxins out. That's all that urine is, basically. So it starts to accumulate and it starts to make you a little bit more sick. So some electrolytes can be imbalanced and stuff. Now, I'm going to go into drawing here. Where do I draw? Sorry, just figuring this out, squiggly line. So our ancestors and the way that our body's made up, it is used to recycling glucose. So our kidneys are meant to close the loop here. They want to recycle it because it's energy, and our ancestors didn't have as much access to food as we did. So it's meant to recycle, recycle, recycle. Now, we're all used to that diagnosis where we ended up peeing too often because there got to be too much sugar that it was recycling. And what happens with our blood vessels is that extra glucose or that extra sugar ends up going into those blood vessels, and it causes a little bit of a traffic jam here. So what our kidneys do basically is it starts sending a detour because of that traffic jam out to our bladder and out into the urine. So that's why we start peeing a little bit more often. This is coming in handy talking about that because that's how one of these medications works too. It makes you pee a little bit more often. I know we all take that as a bad sign, but we'll talk about some of the benefits, possible benefits for some people out there. But like I said, because our ancestors went many days without eating, our kidneys got really good at recycling glucose. And it's because on that rainy day, we're going to need some energy. And just because we don't have it right now, oh, sorry, I'm going to go up here and admit a couple people.
Does that increase the probability of UTIs, urinary tract infections?
It does when your blood sugar is really high. Yep, you got it. Because then you have a lot more sugar in your urine, and bacteria love sugar, basically. So they're going to hop on board. They're going to be like, "Hey, Bob. Hey, Susie. We got a party on Bob here. All expense paid." And basically, they get as much sugar as they want. So that is one of the reasons why that can happen. So I talked about they aren't able to filter out the toxins as well as they used to. They're meant to recycle that. Now the other lab that you end up doing is peeing into a cup is the common one. And so that lab or a common cup, I guess I'm gonna have to erase here too as I go. Is that working though? The drawing's fine on there. You guys can see things. Yep. Okay. Thank you for the feedback and bearing with me here. I'm trying not to have as much technical issues as they did at that ADA 2020 review. But anyways, the microalbumin is basically your peeing in a cup. What does it measure? It just measures how much protein is going through your kidneys, basically. Now, the big issue with that is your kidneys really aren't supposed to be filtering protein. It's not supposed to be going through. So in that kidney, what is attached to it, basically that opening is not able to close and open like it should, kind of constrict but widen. So protein's going through the kidneys and it's going out through your urine. So one thing to keep in mind, if your test is positive for microalbuminuria, just to let you know ahead of time, your doctor will likely be talking to you about being on an ACE inhibitor, which is something like lisinopril, ending in pril, or an angiotensin receptor blocker, ARB, like losartan. So these are just a couple just kind of covering the bases here that when this test is positive, or if you have chronic kidney disease, your doctor is going to be likely putting in these medications because it helps protect the kidney and prevents further progression of kidney disease. Okay, so we're going to talk about a lot of natural things just to keep the kidneys running as long as possible, you know, preventing anything close to dialysis. Like I said, your kidneys can go a long period of time before it even needs that, and they can do pretty well even in the stage 3. People can be in that for years. I've seen them also at diagnosis because the body's working so hard. I've seen them down in these stages and it was almost very acute, and when their body started to heal, their kidneys went back up to greater than 60 milliliters per minute on that study. So that's what I want to kind of highlight a little bit more here, is just because we have some of these labs that have been flagged, there's going to be some pretty natural ways that we can basically heal our body, heal up our kidneys. We're going to talk about that liver too. Okay, so a couple ways to work with kidney disease. Of course, as we know, one of the big ones is improve our blood sugars. what happens when we improve our blood sugars? Basically, we are going into our blood vessels where all that extra glucose is, and we're decreasing that glucose traffic jam so things can flow a little bit more appropriately. We think about traffic jams or construction work. We get a lot more of that in Minnesota, of course. We're not moving too far. Nutrients can't get to where they need to go with high blood sugars. So that's one of the ways. Another way, improving blood pressure prevents damage to the kidneys. Drinking water is a really underestimated thing, and I'm not just talking about coffee or tea or diet sodas. We want something that's going to help wash out nutrients that your body doesn't need, washing out the toxins. Without enough water, the highways, I kind of refer to blood vessels as highways in your body, become very narrow, kind of like one-lane roads. And that's so they can continue to transport water throughout your body. So basically, if your body doesn't have enough water, it will start to shrink that blood vessel into a smaller area so it can still perfuse your brain and all the way down to your feet. But if we drink enough water too, we get a little bit wider highways to kind of transport things through our body up and down. Can people still hear me? It says my connection's unstable here.
Yeah, I lost you for a few minutes.
Yeah, you dropped for a second.
Okay, gotcha. It sounds like it's working now, though. I'll get that recording out too, but
Somebody asked a question, does carbonated beverages count?
carbonated, so, oh, that's a good question. Carbonated. So
Carbonated doesn't count because there's no sodium in it.
yeah, it depends what's added to it when it comes to the flavors, but generally water can absorb more things into it. That's still probably a better alternative than diet soda, I would say, or
No.
some of other things.
They mean boobly or LaCroix.
LaCroix, yeah. Yeah, that's a good question. I don't think,
It tastes like water, you know?
yeah, but it does have a little bit of flavor to it too. So I haven't looked at too many studies when it comes to comparing those two, but that's probably better than diet soda or something like that. But I still recommend drinking the actual water that our bodies are made out of, because that still has a little bit of natural flavoring in those guys. So probably we'll be able to remove a little bit more. Now,
How premium beer doesn't.
did you say beer there, Dick?
Green Belt.
Grain belt?
Yeah,
You're saying that's close enough to water?
it's got great water in it.
Yeah. I wasn't
There
sure.
are some of the waters that do have some of the artificial sweeteners in it too, so you have to be extremely careful about looking at that too,
Mm-hmm.
because those mess up the stomach and all kinds of stuff.
Yeah. I just recommend going with good old faithful, what your body's made out of and stuff, what our ancestors had a lot more of. And I've had many, many patients come to me and just say, you know, I hate water, it's disgusting and stuff. And I think we just kind of became a little dependent on all these different flavors and everything that we've had. But, you know, for them, maybe a good step is the carbonated waters. But
Hey, my constant companion is this little drug that
What?
this,
Didn't hear.
my
Can't hear.
Can you hear me now?
yep, I can hear you now.
So my constant companion is this little drug
Can't hear you at all.
that I,
Your
Don't
mic's
worry,
not-
Laura. I'll be able to tell people.
all right. So I use ice water, and it really, for me, increases the pleasure of consuming water on a regular basis immeasurably.
Mm-hmm. So he's just saying he carries that around with him, has that water to help him out and stay on track with the water there.
And it's ice water.
Ice water, especially
Yeah.
when it's a little bit hotter right now. One other thing I want to kind of mention too is if we don't replace water in our body, it's kind of like running your car without oil, basically. And we all know what happens to the engine with that. One of the biggest reasons why people do get kidney disease is actually just a brief session of dehydration. of severe dehydration, the kidney takes on a little bit of damage. So we always want to make sure we have enough oil in the tank, so to speak, so you're getting enough water to keep your kidneys hydrated so they can work for you for a little bit longer. Now I realize it can be a big issue later on in life when you're like, I'm peeing all the time, but usually after increasing your water intake by, let's just say 1 glass per day, you don't need to do 8 glasses, for example, but usually your blood vessels are, say, this wide, and you start to drink a little bit more water. Well, you're going to be peeing a little bit more because there's some resistance from this, but over time, probably about 3 to 7 days, those blood vessels will start to widen a little bit more. And as they start to widen, you won't be peeing as often, so to speak, as long as you have good kind of muscle reflexes for your bladder too. So that's usually what I hear is people kind of being like, oh, I pee more often when I do this. Well, usually over time, you will start to reduce the amount of times that you're peeing if you just started drinking a little bit more water. Mark Oldham had a good question. How much water should a person have per day? I'd really recommend 2 to 3 liters of water, which is about 64 ounces. It's kind of hard to say there. You know, we're thinking around 2 quarts, 2 liters. That's always a good option of water. And we're really hitting home on this too, like I said, because it's a precursor for these drugs that we're going to be talking about. Not that everyone's going to jump on board or anything, but it's good to know how these medications work and where it can go wrong, basically. Exercise, of course, is always going to improve your blood circulation and help the kidney filter toxins more efficiently. Now, I'm going to do a little bit more doodling here. Stay with me on this kind of magic school bus ride. They did talk about fatty liver disease in that ADA session a little bit, and I had a couple questions on that and how that works. Now, the lab value that you usually run is about once per year, and that's called a comprehensive metabolic panel. It usually has labs such as AST, ALT, and ELK-Phos. Now, majority of people that do have non-alcoholic fatty liver disease don't really have high values on this. I would say about 25% of people that have NAFLD have elevated enzymes in the liver. And you're going to see these towards the end of that lab value. So we're diving into this because this isn't very common for type 1s, but type 2s, before they get type 2 diabetes, usually they have a fatty liver disease way before they even get diagnosed with type 2 diabetes. And I'm going to be diving into this magic school bus kind of thing here and talk about why that is and why sometimes you might seem like you're getting more insulin resistant in your body. Type 1s seem to become more insulin resistant with a fattier liver and or some weight gain. You might notice, hey, this insulin's just not working as well as it used to. Okay, so fast forwarding in this little diagram on the left here, I'm going to talk about the birds and the bees. Just as a guy is attracted to a girl, insulin is, of course, attracted to glucose. So basically what our body wants to do is pair all this up. Of course, we're injecting insulin for that glucose and whatnot, but where these guys end up going to is they get stored for later. Energy is just basically, glucose is just like energy. And our body stores it for later in fat cells or as fat cells. You guys might have noticed with the American diet and stuff, it's pretty hard to maintain great blood sugar levels because it has a lot of carbohydrates. So a lot of this extra glucose and insulin ends up getting prepared into fat cells. Can you guys see me drawing on this just fine? A little bit. So that glucose and insulin gets prepared by the liver, or basically it gets processed, that glucose and insulin, to become fat cells. But because the liver has a great amount of extra glucose that it can't utilize and extra insulin, he actually gets bombarded with fat cells inside the liver. So now the liver a little backstory on that basically is our liver and our ancestors, it's meant to store extra glucose and extra energy because they went for 2 to 4 days, sometimes without eating. And it's good to store a little bit extra when you're looking for food all the time and you don't have anything. So we talked about our kidneys first, kind of storing extra glucose, recycling that, but our liver also is meant to store extra glucose or energy when it comes to it. So it stores a certain amount, but when that liver starts to get inundated by extra fat cells that it has no more room for, our body starts to become insulin resistant, basically to save his life. Now, what I mean by that, by becoming insulin resistant, is that all these fat cells are accruing around the liver, and the liver is an important organ, of course, in our body. And if we kept on storing extra fat cells, he wouldn't be able to work or operate at all inside of this body. So when we become insulin resistant, what that does is it gives the liver more time to ship out these fat cells and instead of becoming fat inside of the liver. So the body starts to store instead those fat cells sometimes in and around the pancreas, because usually people are producing a lot more insulin right there, so the glucose and the insulin can kind of pair in there, or other parts of the body. But the liver plays a big role in our insulin resistance a little bit when we have a little bit too much stored up over time. Then sometimes we need a little bit extra insulin almost to get that glucose to go inside the cell. So a little analogy I usually use is if you think about people in Japan, for example, and they're all trying to fit inside the train, like the security guards are there trying to push the people into the train, and there's so many people there. Well, one thing that they need is they need extra security guards, and that's kind of like extra insulin to push all those passengers into the train. So extra security guards can push extra people into the train. So sometimes it's not necessarily that we're insulin resistant. It's just that we need extra insulin to store more glucose into the cell. Running out of time. Do you guys know if you have to upgrade your Zoom, by the way, in order to get more than 40 minutes nowadays?
I don't know.
Okay. If
You have to pay.
Yes, you do again.
You do again? Okay. So if that happens, if anybody gets dropped, just re-enter in. I'm going to just reboot this one, and you guys should be able to restart that.
Good plan.
Okay. All right. So, sorry, just recapping this a little bit. What our body does with this high glucose, high carbohydrate diet, we have too much energy and we're not using up that energy enough with exercise because we're not walking as much. We're driving cars, of course, myself included. I'm not immune to this, but our body has to store that extra energy basically in a bank account. And that bank account is in your liver. And once that bank account gets too big, your body becomes more and more insulin resistant. To give that liver some time to process that fat and ship it out, instead of accruing more and more fat, and then he can't work as well, if that kind of makes sense. Now, we need more and more insulin, therefore, to get our blood sugar levels down. So that's kind of like having those extra security guards. So more insulin, extra security guards to push everybody on that train. So that's a little bit about lab values. Now, what can we do about liver function when it comes to it? So what we're doing with liver function, exercise, it makes insulin more effective and can lead to weight loss. And it can also utilize extra glucose or energy stored in the liver or body. So you can use up some of that extra glucose, making you a little bit less resistant when it comes to it. Okay. One other thing that you can do, drink more water. That's just kind of a given. That's with the kidney too. You can drink a little bit more water to help remove some extra toxins in your body or to mobilize excess storage that you have. Another one I just want to kind of put out there, I mean, I can't medically recommend it, but fasting. You know, we go through that period of storing up a little bit extra food, a little bit extra energy. Well, when we're fasting, we're more in a garage sale kind of mode. So we're using up that extra storage in the liver. And when we use up that extra storage in the liver, our liver has better chance to breathe and to work and to do its job normally, basically. So fasting is pretty loaded because there's many different ways to fast, and lots of times you need to change your insulin doses too. So really you should be kind of talking with some kind of healthcare provider before doing so, or just making sure that you're safe and that you kind of accept that, hey, I might go low or a couple things might happen. So with fasting, basically, we're just taking this little liver right here and we're just kind of removing some of those extra fat cells. So a common question I get is people saying, I don't eat breakfast in the morning and my blood sugar levels go high. Now, we've kind of been told and bred to think like, hey, I need to eat all so often, but our body is either A, storing energy, or B, it's garage sailing. And so when we are skipping a meal or we're not eating at breakfast, our blood sugar is going higher, what our body is usually doing is it's opening up old glucose cells in our liver and it's utilizing them. So sometimes our blood sugars go a little bit higher. Now, if you do that over a period of time, you're going to notice that your blood sugars won't go as high when you skip that meal because your liver is starting to repair itself. It's starting to get all the stuff that really doesn't belong there out. So it's working a little bit better, so your blood sugar shouldn't go as high. It's not opening up as many glucose cells. So that's kind of the theory of why, you know, some kind of intermittent fasting or whatever can help some people. I'm not totally recommending it offhand, but just kind of trying to paint a picture about why that can help. Any questions so far people have or anything? Hope I'm explaining that okay.
Yeah, I have a question, Brad.
Yep.
When you say fast, does that mean you're going to go for 24 hours, or does that mean some other time period? How do we define fast?
So breakfast just means you're breaking your fast, but I do plan on having kind of an all about fasting presentation coming up here soon, just talking about the different types and whatever.
Okay.
But if someone's just introducing into it, I would just say maybe it's going 1 hour longer than they usually do. And what we don't want to do is we don't want to be like, oh, I didn't eat for that time, now I'm ravenous, now I'm going to overeat. That's why the medical system is not recommending, is recommending these amount of meals all the time and structured, is because they think that a lot of people are gonna therefore overeat. Now, when you are fasting, you are drinking water. You can drink as much water as you want when it comes to it. You don't wanna do a huge amount in a short period of time, otherwise you can really mess yourself up. But we'll probably talk about that the next time. I think that's gonna open up a can of worms there about fasting. But usually you're just doing what you normally do and you might add another hour or something like that.
Got it.
Mm-hmm. All right. Who's heard about time and range? Everybody heard about that? Yeah. So it's just going to be a little recap here, guys. The big consensus, once again, not a surprise, A1C versus time and range. A1C is becoming a part of the past. It's only there for people that are not having CGMs. Of course, CGMs are, a little bit expensive, not easy to afford all the time. But this little picture on the right side just kind of highlights how each of these patients has an A1C of 7%, but the time and range becomes a little bit important because when you're more in range, you're not using up your adrenaline, your body's not compensating for higher low blood sugars, and you're not having that brain fog or that kind of mood going up and down all over the place when you're hitting those highs and lows. So A1C, all I'm just recapping is A1C is starting to become a thing of the past. It's no longer the gold standard when it comes to it. And so we're really looking at like, why was my A1C that? My blood sugars were this, but you can see people can have the same A1C, but they can have completely different blood sugars on average.
Can you tell my doctor that?
You
I
can,
think some of the doctors are doing it. I know my doctor gives me both, which is really nice.
mhm. Yeah, it's nice
Could
to,
you also speak to why people wouldn't maybe wear a CGM or don't have the ability to, where A1C might still be useful?
is that Mark or who was asking that, by the way?
Willie.
Willie? Um, can you repeat that one more time? Sorry.
So A1C is a thing of the
Oh,
past,
why
but
would you
what
not
about
use
people
CGMs?
that don't want to wear or can't wear?
Mm-hmm. So great question. Usually it comes down to affordability. So people aren't able to sometimes afford them. However, there is a Facebook group that if you have old Dexcom transmitters, they can refurbish them for $55. There's a lot of other Facebook groups where they have extra sensors that people can use if they need them. I know the Dexcom G5s, there's tons of extra sensors out in surplus that people can get for free or donated. It's just they have to get their own transmitter. Okay, with that, we're going to talk kind of about what they found out with metformin and type 1 diabetes. Does everybody kind of know what metformin is? They've heard of it before with type 2 diabetes?
Isn't it a bad drug? Don't they say like, oh, get off metformin as fast as you can?
No, I wouldn't say necessarily it's a bad one. There was a recent release that there's some batches coming from India or China, basically, that have a little bit extra NDMA. That's not Molly, that's just a cancer-causing product in it.
Oh, God.
That's kind of a filler. It's still to a very low extent, but there's a new company that's testing, really taking each and every batch and looking really closely at it to see what are these companies putting in for fillers? Are they actually doing what they're saying? Because there's so many companies that want to make the generic right away that they're making these generics and they're cutting shortcuts, and the FDA is not able to keep up with it in time. So otherwise, metformin is kind of the gold standard for any doctor when they see someone with type 2 diabetes. That's all the protocols say that first. However, I would argue actually GLP-1, but I'll dive into that here in a little bit. But this was something called the removal study. And so this just kind of measured, you know, how this worked for people with type 1 diabetes in comparison to placebo. It wasn't significant really with the metformin, but as you can see here, they did have a small decrease in their A1C. They did decrease their amount of insulin by, 1.2 units per day, which is very slight. It was kind of very small. They also had a weight loss of about 2.6. Metformin, the way it works is it decreases the amount of glucose that your liver produces, basically. And once again, your liver is producing glucose because, as in the ancient days, our ancestors, they didn't have as much food as that we have. They didn't have as much access to it. So basically, metformin is just telling your body to kind of ignore, hey, we don't need to make so much glucose because we got enough of it coming into our system each day. So that's why it leads to a little bit more weight loss. Glucose, when it pairs with insulin, will become weight gain. Okay. There's a little bit of a cholesterol decrease when it came to metformin. Basically, they just said it wasn't a huge meaningful impact, but some people do this a little bit with metformin. There's even some endocrinologists I've heard that start people with type 1 diabetes on basal insulin and metformin. And they do that to prolong the honeymoon sometimes. Sometimes it works, sometimes it doesn't. It wouldn't be my approach, but it's not uncommon actually to have some endos use a little metformin with some type 1s early on that I'm hearing. Now it's all off-label, of course. It's not recommended when it comes to it. Only insulin is recommended. The next medication class, and once again, I'm not trying to push any medications. I just know that many of you have lived with diabetes for decades of years, and it's really hard to lose weight when you're having a kind of weight gaining product put in you all the time. And when your blood sugar is high, you got to give yourself more insulin, and it can be really tough to sometimes lose weight. So sometimes, and it's usually with type 2 patients or whatever, I might give them maybe a GLP-1, which is what we're going to talk about, to be in the back corner, kind of rooting them on for weight loss until they feel like they can believe or do this on their own. I only want medications to kind of be that pillar, that help, that little boost, but I'm not trying to push this on anybody. It's just the studies now, they're starting to do more studies with type 1s and these type 2 medications. Okay. GLP-1s stands for glucagon-like peptide receptor agonist. Try to say that 5 times fast. Brand names you might hear it by is Victoza, Bydureon, Ozempic, you know, Byetta, Rybelsus, and Trulicity. You're going to see a lot of commercials for this class, and primarily because it's one of the biggest silver bullets in the weight loss industry in a long time when it comes to it. Usually they're giving people that want to lose weight Phenagrin or Topamax, which has a nickname of Dopamax because it makes you feel like a dope sometimes. For some people, not everybody. This is usually an injectable medication that's taken once daily or once weekly. Rybelsus is the only form that is oral medication taken once daily on an empty stomach. I wouldn't even go down that route if you take levothyroxine or Synthroid, if you have a thyroid issue, because usually you have to take that by itself and then you have to take this by itself. So basically you're spending majority of your morning waiting to take another pill. So just a little fun fact for some people there. What this medication primarily does is it helps someone feel more full and less hungry, basically. Someone's less likely to snack and may even feel nauseated if they overeat. If they start to eat a whole bunch, they're going to feel a little bit more nausea. Well, that's one of the side effects that we'll talk about. Some people don't get that much. This is rated as the #1 medication class after at least trying metformin. Like I said, I think the ACE agrees with me too that it's really even more important than metformin now, or it's at least helping people lose weight and sometimes reverse type 2 diabetes. And so, oops, sorry, it's going back and forth, letting people in. This is also used in non-diabetics for weight loss. The Victoza name for non-diabetics is Saxenda. It can be pretty expensive, but you know how people will pay for their, some weight loss when it comes to it. So it can help them lose weight or become more insulin sensitive. So the studies, excuse me, that they saw at the 2020 ADA scientific sessions kind of highlighted how Victoza, I mean, it really went after Victoza. I wouldn't recommend Bydureon because they didn't have as great of results either. But it did show in one of the studies that their A1C dropped by about 0.5%. The other one, they said it wasn't statistically significant. It was probably still 0.1 or 0.3. Just not enough for them to say this will happen with majority of people that go on it. You can see the weight loss in this first study. People are losing about 13 pounds compared to placebo. And in the next study, depending on the dosage that they took, they lost anywhere from 5 to about 11 pounds when it came to it. So like I said, it does make you feel more full for sure. #1 side effect is nausea, and that's about 10 to 15% of people. A lot of people don't feel anything if you're titrating up slowly or you start at the absolute lowest dose. And other things that can happen if the nausea gets really bad, there are some people, it's just not for them, and that's fine. Everybody's got a different journey. Vomiting can happen, or diarrhea, but like I said, nausea is the #1 side effect. It's about 10 to 15% of the people. 85 to 90% of the people do great when it comes to it on it, or do pretty well. No increase in DKA when it comes to it. One of the big contraindications is using very cautiously with people with pancreatitis, a history of pancreatitis, and it does have a slight chance of causing, very, very slight chance of causing pancreatitis. So once again, it's not like all these medications are magic bullets, but when it comes to type 2 diabetes, it's definitely helping a lot of people kind of reverse it, lose some weight, or have better heart outcomes. And Kathy just kind of mentioned that Trulicity is better than Byetta. I would never recommend Byetta for anybody. It's too cumbersome. You take it 2 times daily. When it comes to it, GLP-1s, pros and cons. So I'm just kind of highlighting what they kind of saw: reduction in appetite, weight loss, 5 to 13 pounds, depending on dose. You know, that was usually over 24 weeks to a year. Usually I see people, if they kind of know what they're dealing with, a lot of patients that I see, this is usually happening in 1 to 3 months that they're getting that amount of weight loss. And then it just kind of depends how much they're staying on top of it. Sometimes the GLP-1s do wear down. And the GLP-1s wear down and you don't feel it as much later on, like feeling more full, but that doesn't happen with everybody. Now, there is a slight decrease in insulin doses that those people did need when they went on GLP-1. Probably some of that's due to reduction in insulin resistance or losing weight. I've gone myself from anywhere, when I was on basal insulin or long-acting insulin, I went anywhere from 12 units up to 35, depending on what time of year and how active I was. So it definitely plays a role with what your weight is and how much insulin you need. There are many benefits with the GLP-1s with reducing heart attack or stroke in type 2 patients. Now, they haven't checked that out with type 1 patients, but usually when you're decreasing the amount of glucose in your body and you're kind of maintaining how much food is coming in, sometimes people are doing a little bit better. Better outcomes for people with type 2 diabetes with chronic kidney disease too also benefited with this. Sorry, I apologize, you're a little dry throat. Okay, cons, side effects, like I said, nausea. It's about 10 to 15% of people. 85 to 90% do pretty good. There are usually samples for people to try. I never like them to go out and buy this because sometimes if their insurance isn't covering it, it can be a whopping cost for this medication. You know, out-of-pocket cost, insurance always charges $800, but lots of times you got commercial insurance, $25 for these medications. Now, these are once again off-label. I'm not recommending it for everybody, but just like you, whenever I start a medication, I like to know all the ins and outs, why people are doing it, what can possibly happen, and how do I decrease those bad things from happening, basically. Now, strategies to help avoid the cons. This is the reason why I like Victoza or Ozempic, primarily Ozempic, is because you can titrate in between doses. So if you're really feeling skittish about it, you can almost take like a placebo, like the smallest amount. Trulicity, you can't go in between. You're just taking kind of that starting dose, and then you ramp up to a higher dose if you tolerate that without the nausea. Now, do not overeat. I specify right here. That's a huge one. Don't overeat. Eat slower in smaller amounts than you're used to at first to avoid nausea. People that are doing that are reducing their nausea down to 5 to 10% from that 10 to 15% when it comes to it. It takes a little bit for your body to get used to, but usually after the first week, people get pretty comfortable with it. Reason why I have this next little area says be cautious if your triglycerides are higher than 500. You might be having pancreatitis, or you might already have it. A lot of providers will not give it to you if you have a history of pancreatitis. The way to check that is by checking your pancreas levels, called amylase. And if that's a little bit high, they might assume you have pancreatitis and they're going to take you off this medication. Now, pancreatitis, I would say it's about 3% of people out there. And I think they're starting to find out that this medication isn't necessarily causing it. It's just that it's happening in the placebo group. It's happening in the other group that people are getting pancreatitis, because people with diabetes are more likely to get pancreatitis, at least type 2s. Once again, I'm basing a lot of this information off type 2s. We did see the studies here that are off of type 1s. You know, be prepared to slightly decrease your insulin doses if your blood sugars are a little bit lower. You know, if you're not eating as often, if you're not regimented, like I eat at this time, that time, you might start to dip in between. So you might be able to decrease your insulin doses, and usually when we decrease insulin, our weight's going down too. We become less dependent on it. Any questions about GLP-1s for people? You can unmute, you can always go into participants or whatever, you can unmute yourself. All that. Cool. We'll keep rocking. SGLT2s. All right, so SGLT2s, what are they? I'm gonna get my little sketch thing here once again and draw. SGLT2s, once again, work with our kidney beans here. So I'm gonna do my best to draw a kidney bean. And our kidney bean usually only recycles, so it recycles glucose quite often until our blood sugars reach about 300 or so. Then it starts telling that detour to funnel out extra glucose into the urine. Basically, it says, hey, we got too much glucose. I'm no longer going to recycle it, basically. What these medications do is it lowers your threshold to about like 150 for your blood sugars. Sometimes other people, it can be 120 too. Basically, it says if your blood sugars get a little bit higher, it's going to be flushing more glucose out of your kidneys into your urine so that you never process this glucose. And what glucose only processes by matching up with insulin, and together, once again, from the liver, they get stored as fat, or just basically energy for later whenever you end up using it. So what this medication ends up doing, therefore, is it can be used for a little bit of weight loss. It can control blood pressure a little bit more, reducing blood pressure. Common names you've probably heard of before are Jardiance, Invokana. There's a few of the other brand names here. And so I kind of talked about how basically if your blood sugars are greater than 150, sometimes even 120, more glucose is going to be detoured out of your kidneys, so your blood sugar doesn't go as high. And so you don't necessarily gain as much weight. Now this is the #2 medication class after trying metformin for people with type 2 diabetes. And the reason why is because, oh, someone say why? I heard somebody kind of sound like a, I don't know. And anyways, the why is because it helps reduce their chance of stroke, heart attack, decrease the progression of chronic kidney disease, and decrease the admission of heart failure too. So that's why these medications you're seeing more and more on TV, because they're working with some people and they're really trying to push them a little bit more. Now, these medications are a lot better than the other diabetes medications that are out there. Sulfonylureas, for example, they lead to a lot of weight gain, a lot of low blood sugars. There's a couple other medications that cause weight gain basically too for people with diabetes, and those are the ones that are being most used by doctors. So these are two of the newer classes. This class, I would say, has been out since 2012 or 14. And when we come back to GLP-1s, these have been out since 2008, basically. So now they're kind of being like, hey, how does this work with type 1s? Let's not forget about them, because they're linked in with those complications, with kidney disease, with heart disease. So some type 1s are talking with the providers about, hey, what do you think about this? And a lot of them aren't going to feel very comfortable, but some of them will when it comes to it. I wouldn't be talking to you about this either too if I haven't experimented with these medications, which I have. I'm not trying to say that my experience is going to be the same as others when it comes to it, but I wanted to do that just so I could experience it and understand it and talk people through it a little bit more if they go through and try these. SGLT2 outcomes from these studies, there was 3 different studies on 3 of the different drugs. They found usually a 0.4 to 0.5 decrease in A1C. They did see 4 to 7 pounds of weight loss, which is less than the GLP-1s, but it's still something. This is an oral dose, once again, oral medication taken once daily. Their time in range increased by 1 to 3 hours per day. And they had a slight reduction in the amount of insulin that they needed daily. So 5 to 15% take. For example, if you had 40 units of insulin daily, 10% would be about 4 units less. So you'd be down about 36 units. Now, there's always some issues that can happen. They did have see an increased slight risk for yeast infection or urinary tract infections when it comes to it. That's one of the hangups, one of the issues that people have with this medication not working. It's probably why I would rank it more of a number 2 rather than the number 1 as well. And there is an increased risk for DKA. So the reason why this medication has not taken off for type 1s, there was actually a type 1 medication called Zynquista. I'm just going to try to just write that here. Zynquista was meant for type 1s specifically, but it didn't make it past the FDA. And one of the reasons why it didn't make it past the FDA was because there was a couple case studies where people were having DKA and they're having blood sugars in the 100s. Now, usually we think that DKA happens when you're 250, 350, 450 or a little bit higher. So they really kind of put on the brakes. I would say it really still is very uncommon, but people on really low amounts of insulin probably shouldn't do SGLT2s. Or people on really low carb diets probably shouldn't do this as much. You can still do it, and I'll talk about kind of what my experience was too. But this slide here kind of highlights the pros and cons to those SGLT2 class. You got that weight loss, you get decreased A1C and an increased time in range, decrease in insulin doses slightly. It wasn't too much in the insulin doses, it was just very slight. Like we said, about 10%. Benefits, once again, reducing chance of stroke and heart attack seen in type 2 patients. And then better outcomes for type 2 patients with chronic kidney disease or heart failure. Glenn's just kind of talking about Zynquista. I had really high hopes for Zynquista too. It came from Sanofi, the makers of Lantus, who really has been kind of sacrificing themselves a little bit in the market, not doing as well, but they went out on a limb for type 1s for this medication and it didn't get approved. And so they kind of lost a lot of ground. But yeah, Zynquista was supposed to do some good for us. The cons, once again, when we're diagnosed, you get that urination, you get that dehydration, you get some thirst too. That can happen. One way to combat that is making sure your blood sugars are not too high. I do not start people on this medication if their blood sugars are commonly above 200, I would say. And that's usually type 2 patients. And if they're commonly above that, they're going to be peeing really often and they're going to have a tough time drinking enough water. Because as you all know, whatever comes out, you got to put back in. And so, here's coming back in. Was that Sarah? Just going to mute you, Sarah. There we go. So there's a slight chance for DKA at lower blood sugar levels like I talked about. That's very uncommon, and that's just more with people that they might be doing a low keto diet or they might be decreasing a lot of their insulin intake. You still need insulin intake, otherwise DKA does happen. So that one's still being kind of followed and better understood. Slight chance for yeast infection, urinary tract infection. Once again, if your blood sugars are really high, or you're going to be peeing more often, then you're going to have more of a chance for yeast infection or urinary tract infection. That's why I say this medication is really not for those that have blood sugars higher than 200 very commonly. Slight risk. This usually gets people, turns their heads. You know, you see all those commercials where it's saying, this medication will do great and you'll be in a sunshiny life for the rest of your life. You know, it's going to be perfect. And then your side effects start to say your head might fall off, you might get cancer, you might get amputations, of course. This one, slight risk for amputations. The reason why, keep in mind your blood vessels, if you are peeing out a lot of fluid and you're not rehydrating, those blood vessels will shrink and they will shrink. They will shrink. And eventually they're going to be like, we need to perfuse your organs and your brain, but we don't need to perfuse your feet. So it's going to start to shunt off to non-critical organs. And because your feet don't have as much circulation, or you're not drinking enough water, that's one of the major reasons why they saw amputations start to occur with this medication class when it comes to it. Okay, very uncommon. Once again, we're going to hear the worst case scenarios, but I did try Jardians. I did try Invokana. I'm not saying that everybody should just jump on board and give it a whirl. There were times where my blood sugars were a little bit higher for a period of time, and I just decided to take it once every other day. I didn't even take it daily. There's no risk if you start it and you just abruptly stop it. It's not a big deal. If people have a yeast infection or DKA, stop taking it immediately. That's a simple solution, basically. I found that I was peeing less frequently when I was having higher blood sugars, and I was taking it every other day. Your doctor will never tell you that, nor am I, of course, recommending that. So this is just kind of an informational session if you want to talk with your doctor sometime, to be like the ins and outs. Is this for me? Is it not? You know, some doctors are like, yeah, you can try it for a little bit. You can try it for a couple days. And if it's not for you, hey, we tried something when it comes to it. Okay. So yeah, there's probably a lot more type 1s that have sampled the SGLT2 class than have sampled the GLP-1. GLP-1s is really if you're just stuck with your weight, having a really tough time. SGLT2s are kind of helping the time and range a little bit more. I think we got a couple members in here that have tried them too, but maybe they're not in here right now. So it's just kind of cool to see these studies that, hey, we have some other things to kind of help out managing diabetes, because it's not easy. It's not this one size fits all by any means. Once again, you guys can ask in the group chat if you guys got questions or something like that. And you can always just interject too if you want to slow me down or if you got questions. No big deal. Ultra rapid insulins. All right, so Fiasp was out for a little bit of time here. It's probably been out for 3 years, actually, since I started pumping. That was probably the main reason why I started pumping. It wasn't approved in the pump at that time, but I was like, I want to just put this in there and see how it goes. And I did. I probably didn't switch back when it comes to it. I'm not using Fiasp right now. And there was an approval of this Longev by Eli Lilly. You can kind of see pictures in here of it. It's not quite to market yet, but these are ultra rapid insulins, meaning they are supposed to act more quickly in the body than Novolog or Humalog when it comes to it. What's the big difference? Of additional vitamin or an amino acid to help the insulin absorb quicker. Now, Fiasp has niacin, which is a vitamin B complex in it, and it's got an amino acid. And this helps it absorb a little bit quicker. I need to have a chart in here. I'll probably send it out here shortly. I should have had that here, I apologize. But it's supposed to, you're supposed to take that Fiasp 15 minutes after a meal and have it work just as fast as the Novolog right before the meal, or 5 minutes before the meal. Okay. All Are they approved for insulin pump? Fiasp is now. That was just since February or March that they approved it. Otherwise, it wasn't before that. And this other medication is not approved. It's going to take a little bit of time for it to come to market too, because it just got approved by the FDA, 2-3 months. Now, are these even worth it? You know, we're talking about this thing. There is news about trials with a weekly insulin, but once again, that's not going to be for people on an insulin pump. It's going to be more type 2 patients, you know, with a newer diagnosis too. So that's why I'm not talking about that yet. Are they worth it? See if your clinic will give you a sample. Easiest way to do that. Prior authorizations can take a lot of time and effort, and it might not even be for you, but you could just kind of say, hey, I want to see if this makes my life a little bit better when it comes to it. And if you do notice that, it might be worth pursuing those prior authorizations, getting your doctor to write a note that this medication helps absorb that insulin a little bit quicker. Testimonials, basically for me, it was working faster for about 1 to 2 weeks, and then it eventually slowed down to Novolog or Humalog. There's a lot of other people that have tried it too that had a similar experience. There are a few people at the end, I say not quite the jump to Novolent R to Novolog. I don't know. I think we have quite a few people that were originally on NPH and R to Novolog. Was that a pretty monumental improvement, would you guys say? You can shake your head or some. I don't think that this one is as monumental, but it's still a little bit quicker. And so when you're rage bolusing, your blood sugar's high and you're like, are you going to come down? Well, this one's supposed to absorb a little bit quicker so that you know, hey, I can bolus again. That insulin has already run its course through my system, and now I can take a little bit more. It's not quite insulin on demand. It was kind of for the first week for me. I could see it as soon as, you know, really working 30 minutes to 45 minutes, and then it slowed down. I didn't see that as much. And I know everybody's a little bit different there too. Okay. But this one's a little bit more popular because these are really targeting type 1s more than they are type 2s. Of course, just an insulin. How does it work compared to Fiasp? Ken, that's a very good question. It's not out there for me to sample or get my hands on yet. So it's still coming to market. They're still supplying their data a little bit more, but they say that Longev actually works quicker than Fiasp in their trial studies. Of course, there's always that way for any product to look better than another with some data. So they're probably skewing it a little bit, but they say that it's supposed to work faster than Fiasp when it comes to it. A couple good questions coming in. Yeah. So let's ultra rapid. Got a new CGM on the market. Basically, it's just a Libre. There's not too much different with it, but it does give audible beeps or alarms that your blood sugar is low or high. Now, I don't know if that's just the set number that you set it at to be low or high. It does not tell you what your specific blood sugar is unless you scan. But this does have a compatibility in the future to work with insulin pumps to automate delivery. They say that this is the only pump that checks your blood sugar every minute. It's still not as accurate as the Dexcom, but it's got an improved MARD, basically improved reliability from the Libre 1 when it comes to it. It'll be available in the US market in 2 to 3 months, likely. So it's not currently yet for sale, but it's something coming here pretty soon. Still 14 days. Still the smallest CGM, I would say, out there. But otherwise, yeah, still 14 days. It only has the audible beeps that says, check your blood sugar, you're low or you're high. It doesn't actually go to your phone and say, this is your blood sugar, unless you scan it. So that's why Dexcom still has that market there, because it goes automatically to your phone without you scanning it. Yeah, so we'll kind of just open it up for discussion, question. You guys can unmute yourself when it comes to it. Obviously, we're here to kind of talk about, the weather, how people are doing during this tricky time. This last slide just is kind of highlighting a couple things. Sometimes it's really hard to be like, oh, I want to try this pump, but I don't want to be committed to it for 4 or 5 years. Sometimes it's nice to test drive it. I do offer that with some people if they want to test drive Control IQ or they want to test drive looping before they decide it's for them. If people want to try different insulin pumps, maybe you want the Omnipod, you want to see how it is without the cord. Also, if you want, weight loss, workouts, yoga, meditation, or just you're traveling around the country, I do free consultations too. If you guys just have a question, feel free to reach out. I know I'm kind of putting this plug and feel a little bit bad for it, but it's super affordable here. I'm mostly doing it for free unless I guarantee something, unless results don't happen. So I'm going to open it up to everybody though, and would love to hear kind of what topics you'd like to hear in the future. I think fasting is probably coming up here eventually when it comes to it.
Brad, my transmitter is going to expire any day now.
Mm-hmm.
So if I wanted to donate my transmitter to somebody, can you tell me where I send it to?
Good question. I'm going to go on to Facebook here and get the link. Now, I do not believe that they are doing transmitters that have the copper nodes on the back of it. They're just doing the ones with the silver nodes on the back of it. And they are refurbishing those, and that's working fine. But I am going